Okay, good evening, everyone. I am Lauren Gates, your host of this evening's Airway Health Solutions conversation series with special guest, Dr. Jeevanan Jahendran, a Malaysian-based ENT specialist. And tonight's topic is integration, the key to upper airway health. Welcome, Dr. JJ, as you like to be called. And I'm so happy to have you here all the way across the world. I think we're like 10,000 miles apart, but it's amazing what technology can do. So welcome, welcome, welcome. Why don't you tell us just a little bit about yourself before I give you your formal introduction? I'd love to hear just kind of your passion and airway and how you got involved as an ENT, just your personal journey, if you would, and then I'll go ahead and give you your bio review.
Sure. Well, I've been an ENT now for almost 20 years now, and started my training in 2000. I graduated from India, and I'm basically a walking airway case. If you ask me to introduce why I'm into this field, I'll probably need a 1-hour webinar for that by itself.
Because we'll do it. We'll do it.
So I had allergies, and I had basically a very bad nose problem as a growing child, and very poor sleep. And so I wanted to do medicine. And then when I got into medicine, I straight away, even during my second, third year, my idea was I needed to do ENT. I needed to figure out what's going on. And so my whole journey, even in ENT, was always about the nose. And as I explored the nose, and then I realized that it's way more than the nose. So 2007, I started going into the general ENT pathway of sleep, which was all the sleep surgeries that we used to do. And I also started dabbling a little bit in CPAP. And in 2012 was the game changer, because we decided to do a sleep meeting, in a multidisciplinary sleep meeting in KL. And one of our two guests were Naresh Punjabi from the Heart Health Study, and the other one was Christian Guilleminat. I think that was the biggest life changer for me, because anyone who you say who's speaking to Christian, and everyone will tell you how he changes your mindset. And he was an amazing guy. So that sort of changed the trajectory in which I was going. And well, still the same ENT approach to sleep and that kind of thing, but in a bit of a different multidisciplinary perspective. And then 2016, I met John Walker. He's a dentist in Boston with Peter Catalano. And we were talking about airway, and it just sort of set off light bulbs, It's like, oh my God, it's like this starts making sense. And then we sort of, over the next 7 years, it's been just evolving. And I mean, when we first started this journey, it was like people were like, you guys are crazy. And now I feel like every day you're learning something new. Every day there's a study being published. But I still think that's a long, long way to go. I don't think we should be standing by the bystanders and cheering that we've got all the answers yet. And so that's pretty much how it went.
I just add to that from your bio, you organized the inaugural Association of Southeast Asian Nations Sleep Congress in 2012, right? And that's really kind of what kicked it off, would you say?
Yeah, and then from then, I think that sort of has a life of its own now. That's moved on into the ASEAN Sleep Federation, and we are part of the World Sleep Society now. And that's pretty much looking at sleep disorders from the early days part of it, sleep apnea and all the other various things. But when this came on board, then I did the other meeting last year, which was the integrative, even that I called it Integrative Airways Summit. And well, it's still going on, and it's still going on. We had Kevin on that. It was a good meeting. I mean, it was almost a global reach. We had 500 participants from all over the world. So that was really something. And then we're planning to do one next year. Let's see.
Hospital of Kuala Lumpur, correct?
Yes, in Kuala Lumpur.
Wonderful, wonderful. So I think you did a great job in your bio. I'm going to let that lie. If there's anything else that you want us to know about you.
Oh, no, let's get on straight.
What do you like to do for fun?
A lot of stuff. I'm actually an aviation geek, so that would explain airflow dynamics. And I'm also a classical music fan. So I really love music. So that sort of keeps my sanity going.
Will you be there at the AAPMD to see the Pulmonauts?
Oh, I actually haven't thought about it, because I'm probably going to Rio for the sleep meeting. So it's a little bit close.
Yes. Okay.
Yeah. So
well, hopefully the Airway Palooza will have you over. Let's see. So before we go into your presentation, I'm so excited for you to share with us all your wisdom. I just want to have a disclosure here that the views presented are the opinions of our speaker and are not necessarily affiliated with Airway Health Solutions. And the following presentation is provided for educational, informational purposes only and does not constitute providing medical advice or professional services. The information provided should not be used for diagnosing or treating a health problem or disease, and those seeking personal medical advice should consult with a licensed physician or dentist. Always seek the advice of your doctor or other qualified health provider regarding a medical or dental condition. Okay, so that's all the back end stuff that I need to do. Let's kick it off because we have so much to learn and we have so many questions that I want to make sure that we get enough time for our Q&A session. So the floor is yours, and thanks again for joining us.
Sure, my pleasure. So let me just get my slides going. All right. Okay, are we seeing my screen? Can you see my screen?
Yes,
yeah,
we can. Thank you.
So I'm pretty much going to be talking today about why we need to integrate our practice and what is it all about. As Lauren has said, this talk is mostly for healthcare professionals, but it's basically my own views and opinion, and does not reflect the opinions or position of any group. I do give I do get honorary consulting and giving lectures for some pharmaceutical and instrument companies. So why are we here today? Now, no matter how much we learn about the upper airway, there's still so much more to learn and integrate. And in my clinical practice, actually, nowadays, when I see a new patient, I always like to ask very basic questions. And the first thing that I like to ask them is, can you name me one physiological function that's more important than breathing? And they just give you this blank stare for a while. And then it sort of dawns on them, there's actually nothing more important than breathing. And then you realize that in medical, at least in the medical line, we are so focused on everything else but breathing. So I said, you can have the best heart, the best brain, the best of everything in your body, but if you're not breathing right, what does it matter? Then the next question will go to, does it matter how we breathe? And I think that's something that is very, very important for us to understand, that we need to understand basic physiology as how we breathe. And the problem today that I see is we need to understand what was meant to be normal before we address what is the abnormal, but more rightfully would be what the body has learned to adapt to with the abnormal structure or function. And I think that's the key to where we are heading today. So I love this slide because, you know, when I try to explain breathing from a medical perspective, it's very difficult. So I always draw this a very graphic picture of the upper airway right down to the lungs and the diaphragm. And then I said, you know, and I'll draw this straw, and I'll say, I'm going to give you this straw. And I said, when you use a straw, is it the straw that's doing the work for you when you drink, or is it something else? Yep. And they said, yes, you seal your mouth and your lips around the straw, and you create a suction force for the water to come up. And I said, okay, now I'm going to put a hole in that straw. What do you think is going to happen? And they said, it's not going to work very well. And I said, remember this. And I draw that straw right parallel to the upper airway from the nose to the voice box. I said, this is your straw with a hole in it. And that's a given for us in normal physiology. That's how we are sort of formed. So how do we make this work? You need to close the hole. And I said, no matter what we do, if you make that straw bigger without focusing on closing that hole, that's still going to be a non-functional or a dysfunctional straw. And all the work is going to be with your diaphragm, the chest wall expansion. And then I tell them that if that straw is going to be maintained and that hole is going to be maintained because that house in which that whole straw sits in is very small, your body's going to learn how to compensate with all the different postures and all the dental malocclusions, whichever way you want to look at it. So I said, it's not an easy game for us to restore all this to normal. And the key we need to understand is it is not just one thing that's going to restore normalcy to this breathing pattern. We need diaphragmatic breathing. So we need some form of breathing retraining. We need to have nasal patency. Now, nasal patency is not just by expanding the palatal floor, because that room of the nose is a three-dimensional room, and there's a lot of things going on in that room. but it's just a room that is only going to work if that hole in that straw is going to be closed. And that hole is going to be dependent on lip competence or seal, and you're going to have the correct tongue against palate posture. And in general, the whole craniofacial respiratory complex, it's Kevin's Boyd's term, it has to be of the correct dimension for that patient, and you need to have correct posture. And more importantly, you need to have integration of oral and pharyngeal reflexes. So it's a very complex game. We know that there are so many influences, from genetics to epigenetic influences, from the maternal stresses to the delivery process, feeding habits, lip seal, atopy, the whole works. So there's no quick fix and there's no easy solution to this. This flowchart basically makes it look what it is today. So you've got the whole end stage problems, from ADHD to pulmonary hypertension to cardiac hypertension to all the neuromuscular dysfunctions to even neurodegenerative conditions that are there if we don't treat breathing. So, and what we need to realize in the airway game is this starts early. So even as a baby in utero, we should start to think now, is the mother, if she's got a compromised craniofacial respiratory complex or a compromised craniofacial structure with very poor breathing dysfunction, which she's not aware of, you're now going to be growing that baby in a very, very hypoxic environment. That means your foundation in which you're starting in that first 9 months, even before delivery, may not be all that great. And we are now showing studies of this. Not only are we showing that if you have sleep apnea as a pregnant woman, you've got a higher risk of developing comorbids like pregnancy, hypertension, and diabetes in pregnancy, but there are even studies to show that you can have intrauterine growth retardation as well. So this is not something that we are plucking out of the sky. There's scientific evidence now behind this. So today, what I'm really going to be focusing on is, we talked about the basis of a changing paradigm when we talked about palatal expansion a few years ago and how it sort of changed the game. But today I'm looking at another basis of changing paradigm, looking at the accumulation of evidence that challenges the status quo. Maybe we just need to change a little bit of perspective and look at a newer horizon. So in reality today, I mean, most of us here that I'm speaking to, it's like preaching to the choir. We all know what we are talking about. But we are a small minority. The people that matter out there are really not aware of what we are doing. So when I still talk to my pediatric colleagues or my respiratory physician colleagues, the pediatric group, they still say, oh, if they see big tonsils and adenoids, they're sending it to me to remove the adenoids and tonsils. And they're not prepping the patient. And when they come to me and they hear this whole different perspective of the airway, they're stunned, you know? And so the pediatricians are literally not aware of a lot of these things. And then, of course, we are looking at constricted craniofacial respiratory complex. Nobody out there is talking about it. Tongue ties, again, very, very focused within the ENT dental circles and the myofunctional group. Again, oromyofacial dysfunctions is something that even within the airway specialties, even within ENT, or even within the dentistry, it's looked like something like, oh, we know it needs to be done, but it's something very small. And we're still putting kids on CPAP, which I totally don't agree with because of the mid-face issues. And look at who are handling these problems: recurrent sore throats, URTIs, allergies. Everybody sees them, from allergologists, immunologists, pediatricians, general practitioners, general dentists. So not everyone is speaking the same language. So we've still got long ways to go. And the medical practitioner routinely seeing these conditions are hardly aware of all these consequences that we are talking about. And the concept that even today, the problems in children are part of growth and development. Well, they snore at the age of 4, 5, fine. They will outgrow it at 7 or 8. But they don't realize that the trajectory of health that we are putting these kids that are going into are not really the best of trajectories that we want them to. So I still feel that we are working in very individualized silos, and because we can't seem to get that commonality in language to speak to others. Like, I know that the dental fraternity in the US has a very big problem talking to the ENT fraternity over there, because we've all built this defensive wall saying that what I do is the best for the patient. So the concept of a group of people, a village of people, as we like to call it, working with dentists, myofunctional therapists, body workers is a very niche area and almost unknown to the other specialties that truly matter. And I think the big paradigm here would be the shift from symptom and disease management to moving towards what we can do to achieve optimal health. And in our game, it's achieving optimal airway health. Now, the same perspective in adults, we sort of like just say OSA is a disease by itself, but no, we know now that OSA is a spectrum disorder and it's an end-stage problem. And we still haven't changed that concept that, most of my ENT colleagues will say that if you're obese, I diagnose you with OSA, I'm going to put you on a CPAP. If you fail, I'm going to get you to see a dentist to put a mandibular advancement device or some oral appliance. If you're a classic, very bad airway case, maybe to a maxillofacial surgeon to consider doing orthodontic surgery. And then, of course, we don't have hypoglossal nerve implants here in Malaysia yet. But so again, it would depend on which specialty the patient comes into contact with. If you come in contact with a surgical-based specialty like mine, we're going to be offering surgery. If it comes into a dental, the first contact is a dental person, palatal expansion is going to be offered, or some sort of dental work is going to be offered to see how we're going to improve this patient. So we still haven't got this right yet. And forget about that. We still think that OSA is a disease of overweight and obese, but in my practice, majority of my patients are thin and lean. They're skeletally narrow. And again, we think that males are more than females. I don't think so. I think females are as affected, if not more than males. And if this is the story, then why aren't patients with medical comorbids being screened for sleep disorders? And postmenopausal females, especially, by the time we are treating them with all the symptoms, they're way too late. They didn't start overnight. They had the risk before they were menopaused, and we didn't pick it up early enough. And then why do we need to do sleep studies? What type of sleep studies? When do we need to do? Who does it? Is it just enough to screen and say that you've got a breathing dysfunction and I'm going to treat it? Are we doing tests post-op to see these improvements? Are they sustainable in the long term? I don't know. We don't have these answers. So my key question to all this is, how do we define success of a condition like this when the condition itself is such a dynamic condition which changes over time, which changes with age? So it's a real challenge. And I think we always talk about sleep and breathing, and even the symptom improvements are based on sleep and breathing, but we are just not looking at breathing. So a patient who has sleep disordered breathing or bad symptoms at night is basically a bad breather during the day. It's just that it's not obvious. So we need to treat what is not obvious to help the problems. And that's where, if you really look into the whole pathway of integration, you'll begin to understand this. So collaboration is not new. It's been there in the early 20th century. Thank Kevin for, giving me all this journals and studies he has shared with me before. So I think we need to go back to this old, this old area of where we used to collaborate together and, get patients to start breathing correctly. Even Christian has said the main thing is to establish nasal breathing. And we now know without a doubt that craniofacial maldevelopment is one of the main issues that are actually causing the dysfunctional aspect of function. And these are all papers that even show how dental issues, the crowding, the overbite, can actually lead to a lot of ENT problems. And this is no longer debatable or challenged because we have shown it now. So we need to work together rather than pointing fingers and say that, look, you're wasting time doing an adenoids and tonsils when 68% of the time the problem is going to recur after 1.5 years or 2 years. We know it. But as an ENT, now when I look at an adenotonsillectomy cases, I'm going to look way beyond the adenoids and tonsils and say that, how can I work with the dentist? How can I work with the myofunctional therapist? How can I work with the body worker to give the best outcome for this patient? So I think the lessons that we have to learn basically from ENT and dentistry is we all have our strengths and weaknesses. We have a very important role. I think our role in terms of managing airway dysfunction is way up there on top of the list. We have to define, or we have to know what our strengths and what our limitations that we can do, why we need to work together, and how that future is going to look like working together. But what's holding us back is cultural barriers. We all have this sense of ego that we are doctors. We have to have ego. Worse still, we are surgeons. Our ego is up there. So we need to really take a step back and say, I can learn more about this. break these cultural barriers, bring this into the curriculum. I think it's so important to start talking about this. I was never thought about sleep in my medical career as a medical student. It's such an important aspect that I think we need to pay more attention to this. For dentists, it is difficult. We've got so many other things to deal with. And even in ENT, we are just too luminal. We are surgeons. When we see a problem, we want to fix it. We are very simplistic in that sense. And we also worry about the finance part of it. We work to make money. Now, you're going to do something that, is it going to reduce our earning capacity, our earning income? So that's a worry again, why I wouldn't want to let go of these things. So we sort of need to get everything in balance. And so what is this integration that, I keep harping about? Well, this is what integration is. We need to work in that little circle in that middle, whether you're an airway dentist, a pediatric dentist, orthodontist, a maxillofacial surgeon, whether you're ENT, peds, respiratory, or even with body workers, we need to sort of get into a sort of system where we need to work in that circle. Why? Because we talk about structure, function, and adaptation, and we can see how it sort of interrelates with each other. Our end game is to get normal physiological function, and in this case, it's breathing. And what we need to understand is we need to put that optimal structure in place. Now, what about adaptations? If you take a 30-year-old young adult who has had a breathing dysfunction for 30 years, when I'm seeing him at 30 years with his open mouth posture, with his snoring, with his forward head tilt, with his tilted body on the side, for him, all this is normal. That's how his body adapted to himself to allow him to breathe, because if breathing is such an important function, the body is going to do whatever it takes to make sure that you take your next breath. So when you're going to deal with the problem, it doesn't mean by just putting everything right, he's going to hold all these things. He's adapted to it. So you've got to also rehabituate to take him out of that situation where he has learned to adapt and bring him into what is normal physiology. We now understand this because we understand it's a complex condition. The etiology is multifactorial. It starts young and it progresses in severity without intervention. It is a vital function that it will adapt until it is not sustainable, leading to associated comorbids. Yet, at least from my perspective, I feel that we are too luminal. Solutions are more of a band-aid rather than curative with sustainable outcomes. And this includes current treatment modalities like CPAP. So if I were to give an analogy, if you can't walk, right, and you need to move around, I'm going to put you on a wheelchair. But that wheelchair is definitely going to help you move around. But it's not going to improve your muscle function. It's not going to improve your muscle strength, because you need to work on something else to improve that. So a CPAP to me is just like putting you on a wheelchair, albeit a good wheelchair, because it's going to help you reduce your comorbids. But I should be thinking in the long run, I'm going to use this as a stopgap measure while I start now understanding what actually happened in this patient from a structural perspective, what happened to him from a functional perspective, and how am I going to bring that into the correct picture and over time get him to function in a normal way. That's why integration is key. So when we understand this, we also realize that from convention, we are moving to precision guided. And what we really need to understand, we need to understand the underlying cause, why the problem happened. You need to know the why, because you want, before you know how you're going to fix it. Look at the modifiable risk factors. No matter how well you fix a person, if that person has got bad sleep hygiene, bad dietary habits, bad stress, if you don't take care of this, you can give him the best structure, you can train him until the cows come home, he's never going to benefit from the treatment. So this is why we need to focus on getting the best out of each and every member of an interdisciplinary team, rather than sitting in a multidisciplinary saying that, I'm going to send it to ENT, please take out the tonsils, adenoids, so I'm going to come back and then I'm going to do a palatal expansion and then myofunctional therapy. We are trying to put all these in nice, neat little boxes, but when our patients are coming, they don't fit into any of these boxes. You got to see every patient from an individual level. So we say form follows function. This is the functional matrix theory. We talk about this all the time. But the question now I've started to ask is, does giving the right form automatically brings about the correct function? Is it a slippery slope ahead? Now, Shireen shared with me this article. She was very upset about it. And she said, rapid maxillary expansion versus watchful waiting. And in summary, they said that they were not able to find convincing evidence to show significant benefit of RME treatment over watchful waiting in patients with pediatric OSA. Well, a lot of people will be screaming murder over this, but we need to show them that when we do this, there is going to be objective improvements. So we learned this lesson in a very, very difficult way over the last 30, 40 years. When we first started doing U3P in the 80s, we thought that, wow, we sorted out snoring and sleep apnea. Well, we all know in which part that ended up in. It only sorted it out in about a third of our patients. We talked about adenoids and tonsils failures. So why do we see these failures? And I think one of the reasons why we see these failures is because we have not assessed these patients very well. For example, I'll share with you a case example. A patient was sent to me with huge tonsils and adenoids. But when I assessed the patient and I said, look, this patient has got a primary oral myofascial dysfunction that led to breathing dysfunction that led to adenoids and tonsils. I said, yes, she's been snoring for years, but that's an adaptation to her. So let's see. Let's start working with her from breathing retraining with myofunctional therapy, letting me get the inflammation under control. So in 1 month, just by getting her on an intranasal steroids, Montelukast, and sinus rinses, the snoring stopped. But yes, the size of the adenoids and tonsils hadn't changed because we have not done any structural work. Her sleep had improved. But the child still went back to the ENT surgeon and he said, look, your tonsils and adenoids are still big. And they took out the adenoids and tonsils. And once you take out that obstruction, there's going to be no symptoms. But your masked oral myofascial dysfunction is sitting there not being diagnosed. And as far as the patient or the family is concerned, the child is not snoring. You've sorted out the problem. But in my books, that has not been sorted out at all. So short-term outcomes versus long-term functional and physiological rehabilitation is one question that we really need to ask ourselves. And any form of space creating, you know, when you do any form of space creating procedure, like for example, if you take out adenoids and tonsils, you're creating space. If I do nasal surgery, I'm creating space. If you do palatal expansion, I'm creating space. But does it restore function? So when I look back in all the nasal surgery cases that I've done over the years, well, when I do the nasal surgery, well, consciously they're able to breathe better because I've improved resistance. But if they have a problem in closing the hole in that straw, do you think my nasal surgery actually worked for them in the long run? The answer is no. So this is why we need to bring everything together. And I think the key is understanding that whatever we do, the sustainability and the long-term outcomes will be the key to define success in the work that we do. Audrey has published this amazing publication, which she shared with us recently. And the key thing that I like to show you that whatever structural work that you do according to the age, it's all in small little boxes. But the key, if you look at the last box, which is functional, myofunctional therapy, nasal breathing, proper tongue posture, chewing, swallowing, address the para functions. This is right across the board. So no matter what we do, the functional rehabilitation has to be a key to whatever structural work that we do. And again, another recent paper that was shared with us in one of our groups, it showed that daily training using self-imposed hypoxia, these are all breathing rehabilitation or breathing retraining, things like Buteyko breathing techniques, has shown that there is some improvements. And when we talk about OSA phenotypes, we know that it's not purely structural. There are other contributions like high loop gain, poor upper airway responsiveness, low arousal threshold. And it can be a combination in a lot of these cases. And that is why we need to understand that there is no one quick fix to this solution. I'm a big person who believes in body work. And I think we cannot do upper airway work without the help of body workers like osteopaths, craniofacial therapists, or cranial chiropractors. We need their help because only now, as a clinical practitioner, I'm beginning to understand the scope of cranial strains, periodic respiratory motion, and all how these cranial strains are actually putting strains on the skull itself and how it can influence posture. we talked about it. When we talk about TMJ, we talk about cervical spine, we talk about angles classification and the different kinds of postures that we get. And this was although it was a very small sample size, it shows that osteopathic manipulation can be looked at, and we want to see objective assessments, objective outcomes with them. And again, that's why they're part of our team. So quickly, just to share with you what we do over here. Well, we work in this team with the dental colleagues, maxillofacial surgeons, myself, ENT, and osteopaths and myofunctional therapists. And the beauty about dentistry is the dentists get to identify these cases very, very, very early. And a lot of the times, the kids that I see come to me very late because they have been treated by everybody else. So when they come to me with allergic rhinitis, not getting better with treatment, I'm seeing them in the adolescent years, early teens to late teens. And when I look at them and in the back of my mind, I'm thinking, well, only I'd seen this kid 10 years ago, it would have been that much easier. So who I wish that people would start seeing this, everybody else, not just us who we are just preaching to the choir. But sometimes, I mean, from a lighter side of things, sometimes I don't like getting cases from fellow ENT colleagues and dentists who are not on the same page, because they are trying, they want to know something, they picked up something, but they're clueless as to what it is that needs to be done. Or sometimes they've done everything and nothing works, and then they send you these really difficult, challenging cases. So it's not really easy sometimes. So how the system works here in Malaysia, at least, is I get referrals from the dentists and the osteopaths, and I refer to the dentists and the osteopaths. So these are some of the referral system that we have. So like, for instance, this is a referral from me from the dentist. They have diagnosed an oromyofunctional disorder, breathing dysfunction, the kind of skeletal malocclusion, and what's their treatment plan, and then they send to me for an airway assessment. So when I do the airway assessment, I will look at the nose, the tonsils, the adenoids, the whole airway, and then I tell them that this is how the progression is going to be. And then we get them to see an osteopath. When the patient comes to me as a first contact, I would now, write up a referral and send it both to the osteopath and the ENT. So we do an assessment first before we even think about starting to treat. And in the process, we start working on small little things, behavioral changes, diet modification, lifestyle management. So these are just like, when I see them, there's a high deviated septum to the left, terminates are hypertrophic. They couldn't assess the postnasal space, probably it was a very young child. The CFRC is deficient in transverse diameter. The oral reflexes present. Tongue is slightly scalloped. Tonsil is grade 1 and there is a tongue tie. Then what are my treatment plans for him if he's got allergies or whatever, and then I'll reassess him. Now, this is a not very uncommon situation that I'm faced with, where I get a referral from a dentist whom I'm not working in the integrative team, in the team. And they send me a case saying that I've picked up this case who is a mouth breather with very, very bad allergies. Can you see this child and, take care of his airway so that I can, and tell me when he's ready for a rapid maxillary expansion. That's all the information I get. And this guy walks in, and it's a horrible case. It's basically a habitual mouth breathing with airway dysfunction leading to craniofacial maldevelopment, very poor sleep hygiene. He's addicted to his screen. He plays games until 2, 3 a.m. in the morning, wakes up at about 9, 10 o'clock, or sometimes gets up sleepy, goes to school, non-functional in school. He's got sleep bruxism, he drools, and he's got issues with eczema. He was a bedwetter, history of childhood atopy. He doesn't chew much, swallows very fast, tends to be a very picky eater, very fidgety, can't sit still, temper tantrums. He had nocturnal enuresis till age 10, very poor sleep hygiene, and he's got underlying trauma. He comes from a broken home. The parents got divorced, and a lot of rebellious issues was because that he just couldn't deal with all that stress. And I had to be very outright with the dentist and said, I don't think this is as simple that you should be talking about a rapid maxillary expansion in this 15-year-old. And I think there's a lot more that needs to be done before we even think of doing any structural work for this patient. So we worked with a myofunctional therapist. We worked with an osteopath. I started getting him to wash his nose, got him counseled. We worked on his sleep hygiene. Today, in 3 months, without even doing any structural work, I would say from a symptom improvement, he's about 50 to 60% better than where we started with. And now we are going to move into the structural correction phase. So I'm a very different ENT. So I have to put it out there that I'm way out on a limb. So when a patient walks in, I look at their gait, I look at their posture, I look at their body symmetry, I look at how they behave in the clinic, whether they're sitting still, whether they're jumping all around, they're curious about my instruments. And then when I talk to the parents, or even as an adult, I look at their birth history, feeding habits, pacifier use, thumb sucking, whether they have any fall or injuries, especially to the head, lifestyle, environment, pollution is terrible over here, diet, what kinds of food they eat, do they take a lot of processed foods, fast foods, and then I spend a lot of time on the sleep history, and then I spend a lot of time on the atopic history as well, explaining to patients why we need to treat the allergy component part of it. In the examination, I look at the facial features, the overall look of the craniofacial appearance, the general posture, the body mass index. I look at the ears for signs of tympanic retraction. I do a nasal endoscopy in all my patients, oral examination, look at the palate, look at the dimensions, look at the tongue movements, see if there's any anterior or posterior tongue ties, scalloping of the tongue, any other lip tie, soft palate, tonsils, and I look for the mandible, tori, the retrognathic or macrognathic mandible, any form of malocclusions, open bite, posterior cross bite, crowding, whether they have a history of braces, and for completion, I always look at the lower airway as well. I do spend, I get all my patients, especially from I would say from almost 8 years onwards, to get a sleep study done. I'm not doing a sleep study to establish the diagnosis here because my clinical acumen already knows that these patients have got problems, but I want to have an objective start point with a lot of these patients, and I'm not looking at the AHI anymore. I'm looking at the arousals, I'm looking at flow limitations, I'm looking at the sleep architecture, heart rate variability, and the oxygen stats. So I'm just going to come out of this and show you what are why I do a type 2, because with the type 2, you get so much of information. So this is just a summary which tells us the AHI, the ODI, whether it's predominantly apneas or hypopneas, the AHI during REM, non-REM, the different types of positions they are in. And also we look at bruxism data as well. So the heart rate and the sleep architecture, the arousals. So I get a summary report and then a very detailed report with all these findings over here. So it breaks down the box and it gives me all the information that I need. So, and you realize that a lot of these patients actually have underlying bruxing and clenching. And this is very interesting because a lot of these patients are not apneic patients. And that is something that we are beginning to look at, and we are doing, and this is using a NOx-1 device, which is an amazing device. And so at least it gives us a starting point to where we start with. And I think that's important. So let me just see, how do I get back in this? So sorry about that. Let me just move this out of the way. Okay. The next important thing that we do is we do a CBCT. And for us, the first screening CBCT is very important because I want a FOV of at least 16/10. I want to see the whole skull. And with this CBCT, for me as an ENT perspective, I can pick out the problems in the nose, whether there's a septal deflection, whether there's turbinate hypertrophy, whether there's adenoids, whether there's any concha bullosa, whether there's mucosal disease in the sinuses. So this gives me a lot of starting point information. So I can already prep the patient and say, look, you've got these kind of structural issues in your nose, which is not going away with inflammatory treatment alone. And at some point when you're ready, 2-3 months down the line, I'm going to be thinking about fixing your nose to help, not as a standalone procedure, but to help the myofunctional therapist or the dentist to get his work better done. So there's a lot of communication in the group. So when we all have that whole assessment treatment together, then we sort of plan out a phase of treatment for this patient. What are we going to do in the preparation phase or the pre-rehabilitation phase? What we are going to do in the structural correction phase, what we're going to do in the rehabilitation phase, and what's going to be in the habituation phase. So we actually draw a plan like this. So basically, when we start off in the preparatory phase, from an ENT perspective, I like to keep the airway clean and nice. So I take care of the inflammation. We get a lot of allergy and non-allergy rhinitis patients here. So I manage that. If it's an adult patient with obvious OSA, I put them on a CPAP trial to see whether I can optimize them with CPAP while we're waiting for everything else. If they got a weight issue, I'll help them down the weight loss journey as well. My functional therapist will assess the patient and see what the dysfunctions are. They'll start off with breathing retraining, tongue exercises, lip exercises, and reflex integration if needed in children. And sometimes when we're talking about skeletal work, when we decide that, okay, this patient is going to be ready for surgery, we'll start working on the breathing retraining and myofunctional therapy for the surgical process, or even with tongue tie release, the preparation of the tongue, the myofascial work, and also to sort of help patients prepare the patients for how we're going to take care of the situation after the surgery. So once we've got through that preparation phase, and then we go down the structural correction phase. And this is where I would consider doing very minimally invasive nasal surgery. That means just giving a little bit of airway to help everything else fall into place. The tongue tie surgery would also come here. If you're planning for orthodontic surgery, then the orthodontic work will come in here. Or when the dentist is going to plan any expansion work, this is where we're going to start working on this. And then we'll go through that whole process depending on however long the patient needs it. Once the structural work is completed, and that's where the real fun starts. Now we need to rehabilitate these patients. What I would say, reprogramming of the physiological function that was supposed to be there in the first place. And then during this time, my work is, as the breathing improves, the inflammation gets less in the nose, I downregulate the medications and just keep them on maintenance, and my follow-up to become longer and longer, and finally we discharge them. From the dental perspective, I think my dental colleague looks at refinements on how to actually keep things in place using either Invisalign or ALF or any other dental appliance, and then continuing or improving or advancing the state of training from the muscle and the breathing perspective. And once we feel that the patient is habituated, we review them maybe every annually or twice a year. And once we feel they're okay, we discharge them. And before I finish off, I'll always like to say that I still trained as an ENT surgeon, and I'm still a surgeon at heart. But what I've learned after 2 decades is a good surgeon is not about knowing how to cut, but when to cut. And I still don't have that answer. We all call ourselves functional surgeons, but I don't know. I need to really figure that out. Are we really still functional? So my take-home message for now would be, structural correction is only a tool to facilitate functional rehabilitation. Identifying the underlying cause is paramount and pivotal in the treatment. And when we understand this, surgery can be more, or any structural work can be more conservative, trying to preserve as much possible normal structure and mucosa. And we need to prevent scarring at all costs. I put this in bold because I don't know this answer. Is there a fix or a standard protocol that we can follow? It is so variable because looking at the underlying causes, it can be so different. I don't know, we may have a general protocol, but I think we still need to think how you're going to manage each and every patient individually. So, who knows what the future is? We've got ChatGPT now to answer all our questions. This is a virtual planning for a nasal surgery, which I thought I'll just share with you, which I just picked up from one of the the computational fluid dynamics side. So you can see how even before you do surgery, you can actually plan how much of tissues that you actually want to remove. And then look at the airflow, where the airflow is supposed to go, and do our surgery tailor-made for the kind of surgery or the kind of airway that you want. Because we know the nose is meant for nasal resistance. Any form of expansion is going to give some reduction in resistance. But are we getting it in the right place? Are we getting it in the right sequence? These are things that we need to show. So this was even before virtual planning. If you look at what I used to do, this is an allergic rhinitis case with the nose that was actually tried to be optimized with medication. But if you see this, you can see how that a very, very minimally invasive just opened up the space in a very minimal fashion. And this is how the nose looks like 2 weeks down the road. You don't need wide open spaces, but you need open spaces in the right place to facilitate the straw, that you've opened it wide enough so that when you close that hole, things are going to work well. we've got the right tools now. These patients are not polyposis patients, or they're not very bad, a lot of things where we don't have to be too aggressive. And sometimes all you need to do is very minimal work to help facilitate everybody else who's working on the patient to bring about the best results. So in conclusion, I think integrative care is the future. We are not doing anything new. We're just rebranding the past. An interdisciplinary care, a team approach would be the ideal way to move forward. We still have a lot of unlearning and relearning to do. And I think once we get that going, I think there'll be more collaborative research that will be coming out, and we will get more answers in the near future. So with that, thank you very, very much, Lauren, for having me. It's really a true honor.
Oh, my goodness.
This is the people that I work with. So I need to acknowledge.
This is amazing. Thank you so much. And the great news is that this is going to be archived on our YouTube channel. It'll be on our website. So everyone's watching. We can do our part and share with the ENTs all over the world. Coming from a peer-to-peer point of view is really, really, really very powerful. So thank you so much for sharing your knowledge, and integration is key. We're all preaching. I know we're preaching to the choir tonight, but I love what you said, is it the people who don't know who really need to know. So, we're doing it our best to raise awareness. And I thank you for joining us on this crusade. We do have a lot of questions tonight, and I want to make sure that we answer as many questions as we can. So any of the updates from Airway Health Solutions will be in the email, and I'll go ahead and review that at 9 o'clock, because I just like to be mindful of everyone's time. But I really want to save these last 15 minutes for the questions that we have. So you just got a nice comments, great presentation from Dr. Harrell. Thank you, Dr. Harrell. And Sharon Moore would like to know, when talking about the ideal outcome, is restoration of physiological functionality that goes way beyond breathing and sleep, the life-giving functions of breathing, eating, and drinking. What's your blue sky thinking? Can we educate our patients to think differently about their health? Can we sow seeds such that our colleagues think differently about concepts of health and disease?
Yes. I was actually told by a colleague in my hospital, and he just came up, he saw one of the presentations that I did, and he's a gastroenterologist, and he just came up and he told me, he said, JJ, you are just way ahead of your time, and we're not ready for this. So even a lot of my own colleagues have told me, he said, what you're doing is impossible. So I said, look, if we don't start it with small baby steps, it's not going to happen. I mean, I'm doing a huge, Sharon knows, she's part of the program in June, and this is not a separate meeting. This is our national ENT meeting, which is an annual thing, which has been going on for 40 years. And they've actually given me a free hand to draw up a program which is very airway orientated in a very ENT meeting. That means at least we are open to the idea to learn something. And I think that's a great breakthrough for me. And I'm really thankful for that. Now, yes, I've been called crazy. I've been called all sorts. But if you're going to start this journey and you're going to have to, go down this path, you've got to be ready to take the knocks as you go along. But, you just have to persevere if you believe in it so much.
Right. So, and it must help so much with the outcomes of the patients that you see. I mean, I would love to follow up with you and show some case reviews of this interdisciplinary collaboration and the stories behind it of the lives saved.
Yeah, we do see, the problem is, when we define success here, right? I jokingly tell my patients, I said, look, 95% of the work is on you, not me. What work we do is a little bit different from conventional medicine. Conventional medicine is you come with a problem, I'll fix you either with medications or surgery. Now I'm looking at you and saying, hey, your health is not exactly on a right trajectory. I'm going to help you put you back on track, but you're going to have to do this. So it's like you go and get a physical trainer and you're going to tell him, I'm going to join your class for the next 3 months. What's your success rate of getting me fitter? That's not how it works. It depends on you. So we are very dependent on compliance. We're very dependent on parent support. We're very dependent on patients. And I think we cannot force this onto people. And I think we really need to get patients and family on board with us first and make that journey along with them. I had a colleague's son, and she interestingly happened to be walking by the room I was presenting at the hospital, and she said, "Hey, this is it sounds like my son, and let's sit down and read, listen to him." And believe it or not, we saw him when he was 13. You know, I don't know, do you have time if I could just share this, if you don't mind?
We're definitely going to have you back, because I'm going to make time. There's a lot of, maybe we'll do a town hall with just this topic.
Let me just pull it up. Now I have her permission to show this, so. Well, don't record this, okay, because it's got his face on it.
Okay, Gerald, can you stop the Facebook Live?
So this is a growing child.
Hold on 1 second, then 1 second, because we are live on Facebook. So there we go. We're off. Okay.
So that's what he came with. And narrow high.
Wait, we're not seeing, I'm sorry, we're not seeing the screen yet.
Oh, sorry.
No problem.
Let me go back to Zoom. Okay.
Yeah, we can see now.
Okay, so he came in as a 13-year-old boy, and he was a habitual mouth breather because of allergic rhinitis. Very underdeveloped CFRC with a high arch palate, restricted lingual frenulum, insufficient tongue space. And that was his LACCAF and OPG. And this was just part of his myofunctional assessment. You can see a lot of compensation on his lips, his tongue. And here we go. He couldn't even lift up his, couldn't do the caving. And that's him 2 years down the line. And that was after expansion. The middle box, you could see what happened after expansion. We got myofunctional therapy still going on. We worked on his posture. And from left to right, the first one is before, the second one is after expansion, the third one is completion with myofunctional therapy. And that's his tongue now. And look at his tongue control. And now this young man actually had Tourette's. And so when we improved his overall function, look at how we changed that spine back to his lordotic curve. I didn't touch his adenoids, but he had nasal problems. And I suggested that we do nasal surgery, but being a doctor's son, you can imagine the amount of convincing I had to do. And the best part was his uncle is an ENT surgeon. So I said, never mind, get a scan done and let's see what the scan shows. And sure enough, the scan showed mucosal thickening in his frontal, deviated septum, a spur on the right, and turbinate hypertrophy, maxillary sinus disease, ethmoid disease. Now, that was actually holding back his treatment. So this was a picture that I showed, that I just did a turbinoplasty for him. I did a septal correction, and I just medialized the middle turbinate by doing an outfracture of the basal lamella. And balloon, we call this balloon sinoplasty of the maxillary sinus and the frontal sinus. And now you won't believe how he is. His Tourette's is almost gone. We are finishing up. He's got an ALF on board now. And we're just keeping him on maintenance with the osteopath. I've down-regulated his sprays and his wash. And the kid worked so much on his health and his fitness that he literally changed the whole family dynamics. Everybody in the family started eating healthy. So
wow.
That's an example of what can be achieved if you work together as a team. And we see that a lot in our patients.
The myofunctional therapists must be thrilled who are listening tonight of how it's just really kind of the start and the finish and everything weaved in between.
Yes. So it's not myofunctional therapists can do everything.
Right.
If you get everybody to build that story of a patient, you know where the problem comes from, and then you can go in a. So this was a case that we did probably about 1.5 years back. But we are also progressing and we are also learning. And from these cases are teaching us why integration is key. I had 2 very bad mental health cases. One was actually a diagnosis of schizophrenia. And in the end, when we took over and we managed the airway together with the psychiatrist, the diagnosis shifted and they said, no, he's actually not got schizophrenia, but he's got just a mood disorder. And we worked on his hygiene, and that patient came to me specifically to see for a septal correction because he couldn't breathe. And I said, there's no way I was going to do his surgery with that kind of, from a non-functional person on 5 antipsychotic drugs, is down to 2, very functional, in a relationship right now, working with his dad's business, and now he's ready for his structural work.
Oh,
so it's
God
not
bless
all
you.
about...
Right. Just a couple of questions here. Why do you not look at AHI?
Because AHI, the problem with AHI is, it is good if you only want to diagnose sleep apnea. Because by the time, if you're looking at the AHI, you're picking them up at the end stage. It's only telling you how much of airway obstruction you have. You can have a breathing dysfunction without apnea or with very minimal hypopnea. Just being a mouth breather alone is going to show you a normal AHI. But I've seen patients with AHI of 2, 3, with very bad sleep fragmentations, with very bad sleep interruptions, with no deep sleep, with very significant clenching and grinding. And these are your cases, which I feel 10, 20 years down the time, when you look at that AHI, you're going to get a positive AHI. So we need to understand that sleep breathing is not all about AHI. It's a lot more than that. It's sleep architecture, sleep hygiene, how you prepare yourself for sleep. You need to get everything right if you're going to get it right.
Do you have any suggestions of how orthodontics and dental facial orthopedics and ENTs can work together and have coordinated curriculum in dental medical school, since we are dealing in the nasomaxillary mandibular areas and in clinical practice?
Oh gosh, that's a loaded question.
I know, but I guess I'm getting so many variations of this question that...
The thing is, we have to start. Like for me, I'm in private practice, and it's so hard for me to do any form of research or to get funding. And when we are restricted because of the things that we can do in private. But I've been, literally shoving this down the throats of everybody, that one of the universities actually got in touch with me, and we've been doing research. And one of the latest studies that we did was, I told them, I said, look, we've got so many allergic rhinitis patients. Why not see what is the kind of, relationship that we are seeing between allergic rhinitis and malocclusion? They made life very difficult to get ethical approval, because they wanted us to make sure that these patients were definite allergic rhinitis patients. We looked at 100 patients, and the dentist looked at what kind of malocclusion patterns, 14 years and above. Do you know what the result we got? 100% of our patients had some form of malocclusion when they had allergic rhinitis. 100%.
Wow. When do we refer, this is from a dentist, to an ENT, what signs and symptoms should we be looking for? And when you have an ENT that doesn't quite believe a dental professional can help, what or how do you say to them in the referral? And should they include a sleep study, CBCT, etc.?
It will depend very individually on each and every practice, I guess. For me, I was very open to it because I realized that there were so many unanswered questions, and I was willing to listen. So even when the dentist first told me about osteopathy, I was very skeptical about it, but I was like, okay, why not? I'll just give it a try. But over the years, I've realized that different body workers work differently. Some of them, their strengths are in myofacial parts. Some of them, their strength are in neural integration part. Some of them are, strong in craniostrains. So as you go along this journey, right, you need to find people, maybe go out for a dinner with a colleague, and just get around talking to them and say, look, but what I definitely advise you not to do is don't be confrontational and don't be upset if you face a brick wall in front of you, because you just got to slowly keep chipping away at it, and one fine day you will break through.
Show them this archive, right? This video coming from an ENT. I'll take another question here. It says, this is from a dentist. In my experience, the first 3 to 4 millimeters of adult maxillary skeletal expansion yields the greatest airway impact. Does continued expansion negatively impact airflow dynamics?
I don't think so. I really don't think so. I mean, when we say 3 to 4 millimeters, right, you also have to, you also have to take into consideration which part of the world you come from. Like, I feel like in our side of the world, we are like the SDB capital of the world. Almost all Asians, if you look at, have got some form of skeletal discrepancy. So we're all skeletally very narrow. I started off with a class 3. And so when we talk about expansion, right, I feel that the maximum space that we get would be the nasal floor. So you're actually opening up that entrance of that premaxilla. But the area of obstruction that I don't feel may be addressed by just pure palatal expansion, maybe the middle meatal area. And that's why that CBCT is helpful. Because if you see a huge concha bullosa or you see mucosal disease, that needs to be addressed by me to help everything else fall into place. Because no matter how much of skeletal expansion you do, for example, right, if you're just talking about symptom improvement, let me give you an example. A parent brings a child into an ENT clinic saying that my child snores and my primary practitioner has said that she's got huge tonsils. I look in there and I said, there's a grade 3 tonsil in there. Let me go take it out. The day I do the tonsil surgery, the next day the child is not snoring. By definition, have I succeeded in curing the patient? The answer is yes. So just like it depends on how you look at that situation. If this patient has got a narrow maxilla with 1, 2, 3, 4, 5 symptoms, expanding it 4 to 5 millimeters is going to take care of 1, 2, 3, 4, 5 symptoms. But what was the underlying cause that resulted in that maxillary deficiency? Was it a skeletal component? Was it a myofunctional component? That needs to be addressed to sustain that long-term physiological function. Because that snoring is not going to come back in that tonsils that I've not removed. But I mean, maybe a few years down the line, it may or may not happen. But that breathing dysfunction, which we are not seeing, is happening even from the day you take out that tonsil. That has not been addressed. Full stop. So you're just masking the symptoms, or you're taking the problem in one place and putting it somewhere else. It's as simple as that.
Thank you so much. I want to be mindful of your time. I know we're 2 minutes over 9 o'clock Eastern time, and you're just starting your day, and you were on call last night. So I really appreciate you joining us today with this wonderful presentation and insights. We would love to have you back, maybe just do a town hall with just some Q&As, and I'm sure there'll be more information to discuss. As you said, there's new information daily, but hopefully we will have you at Airway Palooza in March 2024. And I will say good night and thank you for joining us. We really appreciate it. I know everyone enjoyed this presentation greatly. Is there any closing statement you want to share with us? Maybe just a words of encouragement, to those who are marching on here.
Yep, just keep marching on, and change will come. I'm so positive change will come. If I had that breakthrough with ENT in Malaysia, it can be done everywhere. It's just an approach. Being very confrontational, being very defensive is not going to get us anywhere. We just need to be open to criticism. We take the good with the bad. We're going to get knocked around a little bit. Some people are not going to believe us. But if we believe in this, that we're going to make a change, just keep going.
Wonderful. Thanks again for all you do and your wonderful work. It's God's work, and we really appreciate you and what you're doing for Airway Health. So thanks again for having us. I'll go ahead and review our upcoming events, but I'll also share this in the follow-up email as usual, so you're staying in touch with upcoming events. And Dr. JJ, please give us the link to your symposium in June, and I'll add that to the email for the follow-up. Okay. Thank you so much again. Good night. We really appreciate you. And I'll go ahead and share some updates for those who want to stay on and learn what's coming up. So I'm going to go right here. Good night. Thank you. So we actually have our adult mini residency coming up with Dr. Moralia this Friday. There are a few seats left. We're almost sold out. We did sell out of our pediatric one. June 2nd and 9th are our next pediatric mini residencies, and then we will have more in September and October. October, we're doing a live pediatric mini residency. We're bringing that back live in Florida. And there'll also be an advanced live mini residency as well. Let me just go to the next one here. The advanced one will be October 13th, 14th, also in Florida. That's live or live stream. So you may want to save the date for that. Again, this will all be in your follow-up email. And we have our Team Myo courses. As you can see, myofunctional therapy is an important component. And we're really excited to have Carice Laguerre and Brittany Sierra give our 8-week private practice myo course and our 6-week private practice myo course. One's geared towards the RDH to also incorporate that in the dental practice, and one is for existing myofunctional therapists who want to learn more. We also debuted our mini myo and it's now on demand. That was a sold out course last month. We got rave reviews over that. So Dr. Boyd was really adamant about providing this this myofunctional therapy course for kiddos between 2 and 5. And we hope you check that out because it's a wonderful, wonderful addition to your toolbox. We are having our mini residency with Dr. Brett Christensen. It was rescheduled from May 5th to September 29th. So reach out and check that out for more information. And our advanced mini residency with Dr. Boyd is going to focus on children under 7 years old. And that's live in October with Dr. Mariah also presenting October 7th and 8th. It'll also be live streamed. And we have our Airway Dentist Locator. So I know a lot of our dentists who take our course, they get new patients from this. I get told all the time that it really has helped their revenue, but more importantly, loved ones and people who are moving, where to go for airway focused dentist. Check out the zip code in you. I know we need a few dentists there in Nevada. We have the East Coast pretty well lit up here in our green, but we really could use more in the middle of the country. So if you're in one of these areas, Montana, we need someone in Montana. So please reach out and think about taking one of our mini residencies. We also have a global presence. So thank you for our global doctors. We appreciate that. Our airway aligners are something that is offered specifically to our alumni who take our courses so they understand the philosophies of expansion. And then you're able to order that directly from Ollendorf Appliance Lab. We have our public Facebook group and our private Facebook group. This is our private Facebook group for airway dentists who have taken our course, and it's become like a little family. We have more members. That was taken a while ago, but people share their cases, share their struggles, share any ideas. It's a nice close-knit group, so that's part of being a perk of taking one of our courses. You get to join that group. And then for those who aren't part of our alumni yet, we do have our alumni Airway Health Meetup Facebook group. So please join that. We'd love to have you, and you can share that with your colleagues. Dr. Gerald Simmons is having his dental sleep symposium next week. So we do get a $100 discount. That'll be in the follow-up email. It's not too late to register. Dr. Kevin Boy is also speaking at that course. And we're excited to announce our Airway Palooza 2024 will be at the Ritz-Carlton in New Orleans, March 15th and 16th, 2024. And we do have registration open for those who attended tonight's seminar. So we're going to have open registration to the public next month. So if you want to get special savings and make sure you get your seat, that'll be in the follow-up email as well. We were going to have a master class. Some of you may heard the last conversation. We're going to actually postpone that to Q3 and Q4. Dr. Brett Christensen is going under some medical issues. So we're going to just have an open forum, an airway town hall on May 3rd. This way for our alumni, we will have our follow-up private town hall series where you can ask specific questions about the courses that you've taken and any issues you may be having or any cases you want to share. But for the general public, we're opening up a town hall forum from 8 to 9 o'clock, just question and answers. So that'll be a really fun-paced, exciting night. So save the date. I believe you can register now for May 3rd, 2023. So that's all I have tonight. I'm going to go ahead and stop the share. And I thank you all for attending as usual. You guys keep signing up and we'll keep hosting because we really want to spread the word around the world. And we thank you for all you do to promote airway health. So hopefully we'll see you May 3rd. And please check out the follow-up email with more information. Thanks, everyone. Good night.